Good evening, friends. Let us recall the surgery questions from FMGE, July 24. In this exam, one of the major role is played by surgery paper, especially paper 2. We had around 40 surgery questions, which can be answered only from reading surgery. We would have answered 40 questions. So most questions are straightforward, but there are around 25% questions which are little twisted so that you cannot answer that correctly. So let us see the questions one by one. In indirect inguinal hernia, which nerve is most commonly injured? In an indirect inguinal hernia, which nerve is most commonly injured? The nerve commonly injured is, please understand, in the inguinal canal, this is deep ring, this is superficial ring. In the inguinal canal, we have three nerves. One nerve is ilio-inguinal nerve. Another nerve is ilio-hypogastric nerve. Another nerve runs along with the spermatic cord. So this is spermatic cord containing vas. So another nerve running along with the spermatic cord is, this is genitofemoral nerve. See, please don't forget, among these three nerves in indirect hernia, which is the most commonly injured nerve means, you should not forget on basic anatomy, among these three nerves in the canal, which is coming through deep ring means, only genitofemoral nerve comes through deep ring. Ilio-inguinal nerve and ilio-hypogastric nerve, they enter the canal in between the muscles. They enter the canal between the muscles. Please don't forget. They enter the canal which is in between the muscles. Okay, enter via in between muscles. So in this, you should not forget one important point. Ilio-inguinal nerve supplies what? Ilio-inguinal nerve supplies root of penis and scrotum. Ilio-hypogastric nerve supplies abdominal wall. Lower part of abdominal wall is supplied by ilio-hypogastric nerve. Genitofemoral nerve is running into the spermatic cord. It extends up to the testis. So it is very important. It is carrying the testicular sensation is also carried by genitofemoral nerve. So this point you should not forget. The first simple question is, which nerve is most commonly injured in an open surgery of inguinal hernia? Please don't forget, in an open surgery of inguinal hernia, the correct answer is ilio-inguinal nerve. But it is not there in the choice. You can see from the choice, ilio-inguinal nerve is not there. So among these three nerves can be injured, but ilio-inguinal nerve is not there. So let us go with the only nerve which is present in the inguinal canal, that is genitofemoral nerve. So please don't forget, open surgery, the common nerve injured is ilio-inguinal nerve. In a laparoscopic hernia surgery, what nerve is injured? In a laparoscopic hernia surgery, the nerve injured is L for L, lateral cutaneous nerve of thigh. See, don't forget the two important MCQs. In a inguinal hernia surgery, we can either do by open method or by lap method. When I do by open method, the common nerve injured is ilio-inguinal nerve. When I do by lap method, it is lateral cutaneous nerve. What will happen if I injure ilio-inguinal nerve? If I injure ilio-inguinal nerve, the sensation of root of penis and anterior 1/3 of scrotum will be affected. So don't forget, this is a simple straightforward question for your exam. So high yield MCQ topic. So first question is, in indirect hernia, which nerve is commonly injured? Simple question. This is a straightforward question, but as I told you, there are some questions which are twisted. There is ilio-inguinal nerve, which should be there, and the choice was not there. The answer, therefore, we are going for genitofemoral nerve. So what is this type of skin graft shown in this? The type of skin graft used in this images, what is this skin graft? It is split skin graft, which is a partial thickness graft, See, what is this partial thickness graft? It is also called as Thiersch graft. It is made up of epidermis and part of dermis. So epidermis and part of dermis are present in this graft. The major advantage of this split skin graft, why we are doing small holes like this in the graft, is to make it for a wide application. So the main purpose is wide application of the graft. So wide application, we cannot use in a small area like a full thickness graft. If I use a full thickness graft, I can only use for a smaller area. Whereas if I use a split skin graft, I can put in a wider areas. So this type of graft is called as Thiersch graft. Okay, the answer is Thiersch graft. See, there is another important point you should know. This question can also be twisted. This is also another question. See, the National Board examiners, all the questions are straightforward FMG questions, but all these questions they made so much twisted. That is a major issue in this question. So this is partial thickness graft with a split skinning. So this is deeper split thickness is wrong. It is split thickness skin is also not correct. So actually the question answer should be E, split skin graft. SSG should be the answer. It will be a thin split skin graft. Thin SSG is the correct answer. So since it is not there in the choice, Thiersch is a thin graft. So we will go with the Thiersch. So the answer here is A. Thiersch is a split skin graft, which is thin split skin graft. The split skin graft is further divided into many more types. Thank you all. Thank you, Surya. Thank you. Adit, please. Any doubts if you have, please post so that we will understand the points, will make it more clear. So what is the type of skin graft used in these images? This is a very important point. Please don't forget, partial thickness graft is Thiersch graft. Okay. So coming to the third question, very favorite question of National Board exams. A 2-week-old child was brought to emergency with a recurrent episode of non-bilious vomiting. He was dehydrated, lethargic, and should be corrected before what should be corrected before performing surgical treatment. So can you come to your diagnosis? What's your diagnosis from this image? Can you tell me what is the diagnosis in a 2-week baby? Single bubble appearance. Yes, this is single bubble appearance seen in congenital hypertrophic pyloric stenosis. So in a congenital hypertrophic pyloric stenosis, it's a single bubble appearance, and these patients will have vomiting. These small babies will have continuous vomiting, and because of vomiting, they have hypokalemia, hyponatremia, hypochloremia, hypocalcemia, and metabolic alkalosis. Because of persistent vomiting, this is a finding seen in these babies. Among these electrolytes, for a baby who is going to be operated now, the surgery going to be done as Ramstad's pyloromyotomy. We are going to do a Ramstad's pyloromyotomy. Before going for this surgery, I have to correct all the electrolyte imbalance. The single fluid which will correct all the electrolyte imbalances, isotonic saline. Isotonic normal saline is the fluid of choice. But again, the same concept, the problem, the examiners have twisted the question. So they have not asked what fluid you should give. That is a common MCQ. The common MCQ for exams is what fluid you should give. That is isotonic saline is a commonly used fluid, which will correct all the electrolytes like sodium, potassium, chloride, calcium. They are asking which is most important to be corrected. Undoubtedly, if the patient is having hypokalemia, we will land up in so much of trouble. Therefore, hypokalemia should be corrected first. So thank you, friends. Thank you all. So hypokalemia has to be corrected first. So that is very important because otherwise babies will land up in paralytic ileus. So therefore, which among these electrolyte imbalance, which is corrected? So you can ask, sir, how can you correct isotonic normal saline? Will it correct potassium also? Yes. When you give isotonic normal saline, that potassium also gets corrected. If not getting corrected, you can add injection KCl. What fluid should not be used in these patients? Can you tell me? Contraindicated. Which fluid should not be used in these babies? Any patients with GOO, what fluid should not be used is the fluid that is to be avoided is, please don't forget, the fluid that should be avoided is ringer lactate. It will aggravate them, it will increase the metabolic alkalosis. So please don't use ringer lactate. So this is a very important point. Third question, what fluid correction will you do for a congenital hypertrophic pyloric stenosis? The answer is first correct the hypokalemia using isotonic normal saline. So this is a common question. So I hope you would have made this question. This is a straightforward question without any controversy. Which incision is commonly used for appendectomy? So this is umbilicus. This is anterior superior iliac spine. This is a line drawn, and at this 2/3, 1/3 junction, this point is called as McBurney's point. So McBurney's point is the name of this point, and the incision name done at this place is called as gridiron incision, also called as MacArthur incision. So incision done at this place perpendicular to this line is called as gridiron or MacArthur incision. So this incision is having one complication, injury of Iliohypogastric nerve can happen and it can result in future direct hernia on the right side. So right side direct hernia can happen due to injury of iliohypogastric nerve. So please don't forget. So what is this nerve commonly injured? It's injured is iliohypogastric nerve in this incision. So it is gridiron incision is a common incision used for appendectomy. Please don't forget this point. So gridiron is the commonly used incision for appendectomy. So there are other incisions used. I'm not going into detail about other incisions, but please remember one more incision I want to tell you here is this incision. This is Lane's incision. Lane's incision. So this is a Lane's incision is an horizontal cosmetic incision at the level of right iliac fossa. We make an horizontal cosmetic incision so that it will be helpful for the females to have a cosmetic look. So cosmetic purpose, we make horizontal Lane's incision. So McBurney's gridiron is a perpendicular incision. Okay, that's the fourth question. A patient following a road traffic accident presented with a subcutaneous emphysema. On auscultation, there was no air entry on the affected side. You can see here on the left side, there is no air entry following an injury. So vitals are unstable. What will you do immediately? So this is a repeat MCQ. There is no doubt in that. This is an image of tension pneumothorax. So classically, you can see tension pneumothorax. This is a picture of tension pneumothorax shown here. So tension pneumothorax picture, what will you do? There will be raised JVP in a tension pneumothorax, low BP, raised JVP will be there, and there will be absent breath sounds on one side. So what should I do immediately? Immediately, what should I do next is insert a wide bore needle in the fifth intercostal space at mid-axillary line. That is the immediate next step. So tension pneumothorax patients who are having mediastinal shift, breathlessness, absent breath sounds, raised JVP and all, immediately put a needle in the fifth intercostal space. Fifth intercostal space, mid-axillary line, so that the gas will come out and the patients will have free breathing. So that's the answer. Insertion of wide bore needle in the fifth intercostal space, followed by intercostal drainage tube. That is the immediate treatment for a tension pneumothorax. First, you should do a needle followed by a intercostal drainage tube should be put for these patients. During excision around the sublingual gland, which structure is most likely to be injured? So this question was mentioned as during excision around the sublingual gland or a ranula. I hope you know what is this ranula. Ranula is a lesion in the oral cavity. So this is a oral cavity. On the undersurface of tongue, there is a fluid collected swelling called as cystic swelling called as ranula. So ranula is nothing but it's a type of cyst which is extravasation cyst. Extravasation cyst of sublingual glands. So it is brilliantly transluminant. It is seen on the undersurface of tongue. So it will be seen attached very closely with the submandibular duct. Along with the submandibular duct, you can see this. And this case, I need to open the cyst. And we have to excise the gland. So during this excision of gland, so previously we were doing marsupialization. Olden treatment was marsupialization, but now is removal of the gland is the treatment done. Removal of gland is a treatment for this ranula, but new update from 28th edition says we can give injection sclerotherapy. Injection sclerotherapy can be used for ranula is a new update, but conventionally what we are doing is removing the gland. So the question is a simple applied anatomy question. When I'm removing the gland, what nerve is seen crossing here? Which nerve is seen crossing the submandibular duct or the sublingual gland? So this is a simple question. Anatomy question. The nerve is lingual nerve. So the question is asking which nerve can get injured in the floor of the mouth. In the floor of the mouth, lingual nerve will get injured. Okay, lingual nerve get injured. So please don't forget this question. So simple question. Very good, Dr. Rahul. So that's a great score. Thank you, Abdul. So don't forget, lingual nerve gets injured in these patients. So lingual nerve is commonly injured in the sublingual space. So this is a new question, but it's a practical question. Actually, no need of any understanding in this question. So this is a question showing you the patient having a lesion in the small bowel. For this lesion in the small bowel, they are resecting the bowel. and they are doing anastomosis. Simple question. This is a small bowel pathology for which resection is done of the pathology. The pathology may be a perforation, pathology may be a tumor, whatever it is. The pathology in the small bowel is resected and anastomosis is done. That is the answer for this question. Answer is B. Resection and anastomosis. The answer for simple answer for this image-based question. Patient presented to OPD with a dilated tortuous vein with a history of trauma 10 years back. On examination, pulsatile vein is also visible. So this is a very important point. You should not forget whenever you get a line pulsatile vein. What is the diagnosis? Pulsatile vein means it is AV fistula. AV fistula, what is the most common etiology? Can you tell me what is the most common etiology of AV fistula? The most common etiology of AV fistula is iatrogeny. For hemodialysis, we do AV fistula. That is the most common etiology. Apart from iatrogenic, other etiology, the second common etiology is trauma. So what happens in a penetrating trauma, if this is the vein and this is the artery, during the penetrating trauma, they do get joined like this, and therefore the arterial blood starts flowing into the vein like this, and therefore the vein becomes dilated, tortuous, pulsatile. This can be detected by doing a Nicoll-Dunny test. Nicoll-Dunny or Branham test. So Nicoll-Dunny or Branham sign, if there is an AV fistula, you compress the artery proximally. So immediately the veins will collapse and the pulse pressure decreases. Please don't forget, the pulse pressure decreases and murmur decreases. Murmur decreases. That is the Nicoll-Dunny or Branham sign. If you compress proximally, pulse pressure decreases and murmur decreases is called as Nicoll-Dunny or Branham sign. Don't forget this line. This is very important. The answer for this question is AV fistula. Straightforward question. So this is again a 100 times repeated question for national board exams, FMGE, NEET PG, NESET, everywhere you are having this question. Please understand, this patient is having on the sole of the foot an ulcer called as tropic ulcer. Tropic ulcer is due to neuropathy. Don't forget this basic point. Neuropathy, where there is absence of sensation, the patients will walk on a hard surface or on a sharp area, and the tissue gets lost. So, and because of that, the tissue gets lost. It's called as neuropathic ulcer or a tropic ulcer. So this is a classical picture. You should not forget. So tropical ulcer is seen on bony prominences. So bony prominences, especially on the sole. You will see on the sole of the foot. Sole of the foot, you get this. On the metatarsal or on the calcaneum, you get this tropical ulcer. So can you tell me where will you get arterial ulcers? In peripheral vascular disease, where is the ulcer seen? It is seen on the dorsum of the foot. Okay, this is a dorsum of the foot. You can see the ulcer on the dorsum of the foot. This is dorsum of the foot. Classically, you will see absent pulses. Absent posterior tibial, dorsalis pedis and all will be absent in arterial ulcer. So they are seen on the dorsum of the foot. Venous ulcer, everyone know the answer. It is seen on the, yes, on the medial malleolus. Venous ulcer is seen on the medial malleolus. See, there is an ulcer which can have neuropathy component plus arterial component. That is diabetic ulcer. Diabetic ulcer has neuropathy, angiopathy, therefore, and secondary infection. So it is a most nasty ulcer is diabetic ulcer. It will be seen anywhere in the foot. Very important ulcer, you should not forget. So these are the points of various ulcer. Tropic ulcer is a favorite FMG question, national board question. Please don't forget this. Here is a simple question. I don't know, many students had a confusion in this. It is a classical red velvety plague. I don't know why some of them went for leukoplakia. Leukoplakia is white. So this is a red velvety plague seen in the oral cavity. It is highly malignant. It has highly malignant potential. Therefore, whenever we see a erythroplakia, the treatment is we have to excise it fully. Completely remove this like this. We have to excise the erythroplakia without leaving a tissue, because already it can have cancer. Here in this picture, you can see there is a small malignancy also. So erythroplakia means always you have to excise the erythroplakia. It's highly malignant. Therefore, you should excise. Here, as usual, the question was not having excision. Therefore, the question is asking, given image, next investigation required for the management. So the investigation is erythroplakia is a diagnosis, and I will confirm it by a biopsy. And treatment is excision. Okay, treatment is excision. So do biopsy for these cases. A young adult patient presented to OPD with a complaint of mass in the testis. An orchidectomy was performed. We have around 35 questions, straightforward questions for FMG exam. So any doubts, if you have, please post so that I can clarify your doubts. Otherwise, I will be going only through the explanation of the question and answer so that you can understand it after you read the regular module from DocTutorials. Our regular DocTutorial module is excellent because around 80% of the questions in surgery we had completed in DocTutorials platform. So you can go through DocTutorials FMG surgery part for understanding surgery in depth. A young adult patient presented to OPD with a complaint of mass in the testis. Orchidectomy was performed. It is a picture showing you high inguinal orchidectomy. You can see classically, it is not simple orchidectomy. It is a high inguinal orchidectomy. Means we removed the testis along with the spermatic cord. This is done at the level of deep ring. So this is high inguinal orchidectomy. And from the testis, we do biopsy. So most common tumor is seminoma. All of you know that. The most common tumor of testis is seminoma, seen in 20 to 40 years usually. So less than 20 years, usually we get non-seminomatous tumors. Non-seminomatous tumors are seen in less than 20 years. Seminoma is most common in overall. In non-seminomatous tumors are seen in less than 20 years. And what is the most common in children? In children, the most common tumor is yolk sac tumor. That is the one which carries the best prognosis. So non-seminomatous tumors are teratoma, yolk sac tumor, choriocarcinoma, embryonal carcinoma. Many tumors are there. So among this, yolk sac is the most common tumor in children, and embryonal type invades scar structures. Choriocarcinoma invades bloodstream. Teratoma and seminoma can metastasis, whereas the only tumor which is very soft is yolk sac tumor. Is a soft tumor with no extensive mets. Okay, so please don't forget this concept of yolk sac tumor. 11th question. So a lady presented to OPD 10 days after delivery with a chief complaint of tenderness and engorgement of the breast. So this is a very common situation where there is no discussion at all needed. A pregnant lady, what symptoms she will come to you? So usually if she comes to you, the most important cause of breast pain is breast engorgement. If she is not feeding the baby, breast engorgement is the major issue. If the breast engorgement will have only enlargement of breast with a mild pain, but usually it is not so symptomatic. Once the baby is feeding the breast, feeding the milk, automatically the breast engorgement decreases. But one another problem in this age group is mastitis. Inflammation of the breast. So this mastitis will in future go for abscess. So mastitis is characterized by painful enlargement of breast. So painful enlarged breast with the putty orange seen on the breast. Whereas when it is an abscess, there will be associated fluctuation present. So the answer for this question is mastitis, not abscess. So if it is an abscess, they would have given a clue. Definitely, they would have given a clue that there is a picture, there is a point of like a fluctuation is seen like that. They would have given the clue. So please remember, it is mastitis. So thank you, Dr. Karthik. Thank you so much. Thank you so much for all your appreciation. Hope most of you have cleared the exam and preparing for NEET PG. Definitely, our DocTutorial platform is giving excellent content for NEET PG also. So you should all subscribe to DocTutorials for NEET PG content. Same faculties are covering. It will be very easy for you to prepare again. Okay. So a patient underwent surgery for pilonidal sinus. What flap is used? See, this is why we always say FMG exam and NEET PG exam, both are more or less same, because the same question was asked in NEET PG. This is the same question asked in NEET PG. It is a picture showing you a classical rhomboidal flap. Rhomboidal or Limburg flap. See, this is a rhomboidal or Limburg flap, which is shown here in the bottom. So it's a rhomboidal or a Limburg flap. Let us first of all discuss about the various flaps. So this is a content taken from our original material. So random pattern flap is based on dermal and subdermal plexus. Accepted length width ratio should be 3:1. So length width ratio, the length should be 3 means width should be 1. So length width ratio should be 3:1. There is no named vessel. We will transpose the flap like shown here. This is called as from one place we are transposing, known as transposition flap. This is an Z-plasty flap. If there is a contracture of the neck, you can make it like an Z and make it like an S. It's a Z-plasty type of flap. So this is a rhomboidal flap. It's a type of transposition flap. It is also a type of transposition flap. This transposition is rectangular. This is circumferential, whereas this is like a rhomboidal, like a rhomboidal transposition flap, very commonly used in pilotal sinus. This is directly our material content used in ARISE academic classes. This material is used. So the same material I have shown here. So this is another rotational transposition flap. Advancement flap, if there is a gap here, we can advance the thing. So advancement flap can be rectangular, V, Y, or obese, many type of named flaps. So, but this question is a repeat question. If you feel this question is difficult, definitely you have not gone through previous year questions. So this is a previous year question of NEET PG. So NEET PG question. So don't forget, this is a transposition flap called as Limburg flap. The name is Limburg or rhomboidal. Okay, rhomboidal flap is shown in this image. So coming to the 14th. Is it coming now? There is a net issue.
Yes, sir. Yes, sir. Yes, sir. No problem.
I'm coming through another issue, another thing. Is it fine now?
Sir, little bit blur.
Blood,
Good to go, sir, now.
Is it good? Okay now? Okay.
Yes, sir. Good to go, please.
So a patient came to you. Here is a question. A patient came to OPD with the chief complaints of swelling in the neck region, which moves with deglutition and protrusion of tongue. There is a rupture of swelling with the pus discharge. What is the preferred treatment for this case? So it represents an ectopic thyroid tissue. So when there is a line mentioning deglutition with the protrusion of tongue, this is a very classical question. This is a picture showing you a lesion which is being ruptured. It is nothing but acquired thyroglossal fistula. Please don't forget, it is an acquired thyroglossal fistula. So the only structure which can move with the protrusion of tongue is thyroglossal cyst or thyroglossal fistula. So there is a rupture of the swelling which has causing a pus discharge is nothing but thyroglossal fistula. What is the preferred treatment? Without reading the choices, you can go to a conclusion. Thyroglossal fistula needs cyst trunk operation. See, as you know very well, the choice of cyst trunk operation was not given in this question. So the preferred treatment is excision of entire tract and cyst. Entire tract is the best treatment. So we have to excise the tract along with the cyst. That operation is called a cyst trunk operation, in which we remove a part of hyoid bone is also removed. A small segment of hyoid bone is removed. It represents ectopic thyroid tissue. Yes, it can contain ectopic thyroid tissue. In the thyroglossal cyst can contain ectopic thyroid tissue. Acid fast staining is not needed. It is not a TB. IND should not be done. It can progress to squamous cell cancer is wrong. It does not progress to squamous cell cancer. It progresses to papillary cancer. It progresses to papillary cancer. Please don't forget this point. It progresses to papillary cancer. So this is a point you should not forget. This is a thyroglossal cyst, but they didn't give the correct choice of cyst trunk operation to be done is not mentioned in the choice. Let us go with the A choice. It represents ectopic thyroid tissue. Yes, it can contain ectopic thyroid tissue. 54-year-old male present with binge drinking and heavy meals was brought to emergency with a sudden onset of left side chest pain radiating to shoulder. Pneumomediastinum was present. This is our classical question of Borow's syndrome. I hope you remember this question. Borow's syndrome, we have done a detailed discussion in our module. So Borow's syndrome is due to vomiting against a closed glottis. In an esophagus, if this is an esophagus, the patient is vomiting after a binge of alcohol, this glottis is not opening. Therefore, the pressure in the esophagus increases and causes rupture, most commonly on left lower posterior area. This results in a triad called as Mackler's triad. So what is Mackler's triad? Vomiting, followed by chest pain, followed by subcutaneous emphysema. Subcutaneous emphysema is nothing but mediastinum. So the FMG exam questions, they just expect you to come to your diagnosis. That's all. They don't expect you more. They just expect you to come to your diagnosis from the clinical history. So this is a picture showing you esophageal perforation. So esophageal perforation, the air from the esophagus will come out and there will be presence of air in the chest, and that sign you all know very well. Radiology question called as Necklerio V sign. See, Borow's syndrome is a favorite question. We have discussed it in detail in our regular module as well as in the classroom. So please remember Borow's syndrome. This is again an 100 times repeated question. Which of the following pathology is shown in the image? So from the image, you can see there is air under diaphragm on the right side. So it is air under diaphragm is perforation of bowel. Perforation of bowel results in presence of air under diaphragm, and you have to take the patient immediately for emergency laparotomy should be done based on this X-ray. So when you see an air under diaphragm, what should I do? I should take the patient for surgery. So it is a radiology cum surgery question. You can see hollow viscous perforation showing air under diaphragm on the right side. See, this is a classical update. See, always see, we say you have to read the latest edition of Bailey and Love. So Bailey and Love 28th edition is giving this image with a detailed explanation. And we had this discussion in our classroom session about the critical view of Strasbourg. Critical view of Strasbourg is an image we get when we are doing laparoscopic cholecystectomy. Please understand, when I'm doing a laparoscopic cholecystectomy, this is the bile duct. Okay, this is bile duct. This is cystic duct. This is cystic artery. So what does critical view of Strasbourg says? Critical view of Strasbourg says when we are doing laparoscopic cholecystectomy, we should dissect the cystic duct and cystic artery, and we should do classical view like this. Only two structures should enter the gallbladder. Then only I should put the clips like this. So this is called as critical view of Strasbourg. Question is asking what is the marked structure? It is cystic artery. So cystic artery is marked here in this image. So this is a cystic artery. This is cystic duct. So this view is called as critical view of Strasbourg. This is cystic duct and this is cystic artery. Cystic artery is a branch of right hepatic artery and cystic duct joins the bile duct. So this anatomy should come, then only we should clamp it like this and remove the gallbladder. Don't forget this question. Critical view of Strasbourg is a favorite question of recent exams. Okay, you should not forget this. What is shown in this image? This is again a repeat MCQ from NEET PG. X-ray of a patient is done. X-ray abdomen shows there is a foreign body-like appearance. What is this? This is a double J stent. Don't forget, it is double J stent shown in the image. Also called as double pigtail stent, which is kept in the CBD, bile duct. So this is kept by means of ERCP into the bile duct. So the answer is ERCP and bile duct stenting was shown in this image. So don't forget, this is a picture showing you ERCP and CBD stenting. Highly expected MCQ. So this is ERCP showing CBD stenting. Okay, this is a picture-based question, very commonly asked in exams. The same stent, if it is found below like this, what is this? Same stent found toward the bladder is, it is 20 centimeter stent. Previously, we used 10 centimeter for bile duct. This is ureteric stenting. Ureteric stenting will be seen in the lower part. Okay, don't forget this point. Which of the following is not an indication of splenectomy? See, splenectomy, I want you to know the basic concepts. Splenectomy can be divided into emergency splenectomy and elective splenectomy. Emergency and elective. Emergency is the most common indication and it is usually following a trauma. So the most common cause of indication of splenectomy is trauma. Electively, the most common indication is idiopathic thrombocytopenic purpura. And all hemolytic anemias we can do. Hemolytic anemias. And selected leukemias, where the spleen becomes massively enlarged. Leukemias, tumors, abscess. So these are all elective cases of splenectomy. So here the answer for this question is, which of the following is not an indication? Trauma, yes, it's an indication. ITP, yes. Hairy cell leukemia, yes. Not for bone marrow failure. Why should I do splenectomy for a bone marrow failure? Especially in a bone marrow failure cases, RBC will be produced from spleen. If you remove the spleen in a bone marrow failure, patient will die. Please remember, bone marrow failure, what should not be done is splenectomy should not be done. Okay, that is why before doing a splenectomy, always we do bone marrow biopsy and confirm there is formation of erythroblast. A patient was brought to emergency with a diffuse abdominal pain and abdominal wall rigidity. Exploratory laparotomy was done and the following finding was noted. I don't know how many of you are observing this finding. This is a ileum with a perforation. So the commonest cause of ileal perforation is typhoid fever in India. So typhoid fever is a commonest cause of perforation which can happen in first week or it can most commonly happens in second to third week. If it happens in first week, it is good prognosis. If it happens late, it is bad prognosis because already patient will be malnourished and very sick. So for a patient who is coming to you with a typhoid fever with a perforation within 1 week, what will you do? That is the question. So what do you do in this patient? So if the patient is looking stable without much contamination, you can simply do primary repair. That is the answer. You just suture this injury with a suture. No need of omentum and all. We cannot take the omentum and keep on the ileum. No need to do like that. It is not mentioned like that in Bayesian law. This is a direct line from Bailey. If you go through Bailey, the various options are number 1, simple closure. One option is done. Commonly done is simple closure. Number 2 option is resection and anastomosis if there are so much of sepsis. Or if the sepsis is heavy, just to do a ileostomy. All these are given in Bayesian law. Simple closure, resection and anastomosis, or just keep it outside, called as ileostomy. So among this, what would you do in this management, in this patient? So this is a case of a yearly case of perforation. So better I will go for a simple primary repair. So this point is again having ileostomy is also there in the choice, but you have to have clue. Ileostomy is done for sepsis and patient, very sick patient. You will go for a simple ileostomy. So let us go with the commonly done procedure, that is simple repair. So a patient was brought to emergency with the flame burns, and you know very well there will be no FMGE exam question without a question on rule of 9. So all of you know that rule of 9 is a very commonly asked question. So see this question. Patient has come to you with the burns involving a left upper limb. This is a left upper limb fully involved. Anterior aspect of chest and abdomen. Okay, left upper limb, right lower limb, anterior aspect of chest. So left upper limb 9%, anterior chest is 18%, lower limb is 18%. So 36 plus 9, which is comes around 45% will be the correct answer. So that choice, the problem is many times the choice will not have the correct answer. That is the problem. So many times 45% is the correct calculation from our side. So 18% for anterior chest and abdomen, right upper limb and left. Sorry, actually this question I'm a little confused. The question is very clearly giving right upper limb and left upper limb. So that means what? There is a upper limb means we can go with 9 plus 9. That is 9 for upper limb right, 9 for lower limb, upper limb right, and 18 for chest. So the totally that comes only 36%. That is correct. So the choice here therefore will be better go with A. So rule of 9 is a favorite question. Please don't miss rule of 9. Keep reading rule of 9. Always it will be asked. So each lower limb is 18, head and neck is 9. But the commonly used chart nowadays is what? What is the best one now? Lund-Browder chart is the best chart, which is a ready-made chart. You can easily mark in the case sheet. That is the best for calculating burns. Latest is Lund-Browder chart. While doing a venesection for a burns injury, which nerve is prone for injury? See, venesection, what is this? So this is what we always say, practical questions. So many times you would have not taken this in the class, but you should understand that a burns patient, the major issue is what? Because of the burns, all the veins will be collapsed. You could not see the veins at all. In such case, I could not even cannulate the veins. Such a situation, what we will do is, we will open the long saphenous vein. Long saphenous vein is opened by surgery, small surgery, by small incision. We hook out the long saphenous vein and then put a cannulation. So which nerve runs very close with the long saphenous vein? That is the question they are asking. So long saphenous vein is closely related to saphenous nerve. See, please understand now the FMGE exam questions have gone to a level. You have to understand the concepts and read. Just mugging up the facts is very difficult to clear the exam. So every question is clinical. You can see I have made all the questions from the direct recall by the students. Every question is clinical question. There is no question like simple one-liner, what will happen, that thing is there. All the questions had a clinical impact. Therefore, you should start understanding the concepts. So this is saphenous nerve which gets injured when I open the long saphenous vein. A patient is presented with the red tender swelling in the inguinal region. The swelling is vascular and pulsatile. What swelling will be pulsatile? So pulsatile is a feature of aneurysm. Aneurysm is a swelling which is pulsatile. So therefore, a patient in the inguinal region is having an aneurysm. On examination, the BP was low, which is the following is most appropriate next step. So BP was low means probably what would have happened is this patient, these are all new questions. So the femoral artery is bleeding and forming a pseudoaneurysm in the inguinal region. This happens following a bypass graft surgery or following a femoral artery. You take a sample at the femoral artery. No, so when you take sample, if you don't do proper compression, that area can get infected and form a infected femoral artery aneurysm. This we call it as pseudoaneurysm. Pseudoaneurysm. So this will have pulsation. So what should I do for this case? Such an infected pseudoaneurysm. First of all, confirm it is aneurysm by doing a angio or by means of duplex. So investigation should be done next. Confirm it is aneurysm. First to do angiogram to confirm the diagnosis. Antibiotics and observation is wrong. We will start antibiotics, but observation is wrong. IND should not be done. Patient will bleed by dying. Bleed and it will go for death. Surgery and inferior epigastric artery. So nothing to do with the inferior epigastric artery here. It is a case of femoral artery pseudoaneurysm as per the picture question. Okay. A patient who has an incisional hernia, which of the following method is shown in the surgical procedure to close the abdominal wall? Please remember, This is abdominal wall. Let us assume this is abdominal wall made up of the following three muscles. So this is external oblique, internal oblique, and this is transverse abdomen. These are the three muscles. So these three muscles join at the center, forming a rectus sheath or linea alba. So this is a linea alba. This is skin. This is fascia transversalis. This is fascia transversalis, and this is peritoneum. This is peritoneum. So now incisional hernia means what? What is incisional hernia? Structures coming out like this is called as incisional hernia. So I can operate it by many methods. I can keep a mesh here. I can keep a mesh here like this. If I keep a mesh like this in front of the muscles like this, if I keep it is called as onlay repair. Onlay mesh. If I keep the mesh on the abdominal muscles, that is what you are seeing in this picture. This is the most commonly done procedure by surgeons. We have done hundreds of procedures like this. So it is onlay mesh. And if I keep the mesh like this below the muscles, it is called as inlay mesh. Sorry, sublay mesh. It is called as sublay mesh. Below the muscles. Sublay mesh. If I keep in the gap itself, it is called as inlay mesh. So inlay mesh repair is not done nowadays. So either we do onlay or sublay. We are no more doing inlay mesh. So this is onlay is above the abdominal wall. Inlay is into the defect. Sublay is below that. Same like onlay, we keep it below the muscles, sublay. Another one which is commonly done by laparoscopy is laparoscopically, I will keep a mesh like this in the peritoneum itself, on the peritoneum. This is called as, in laparoscopy, it is going like this. No, so it is called as intraperitoneal onlay mesh. It is called as intraperitoneal onlay mesh. So don't forget this. So this is IPOM. Its surgery is called as IPOM. But in a open surgery, the mesh kept are like this. Onlay above the muscles, sublay below the muscles, inlay into the muscles. So this is a picture showing you onlay repair. Which of the following is correct regarding the patient who presented with the following as shown in the image? So this is a picture showing you obstructed umbilical hernia. Obstructed umbilical hernia. This is a picture of obstructed umbilical hernia, which was previously reducible, now has become irreducible. What should I do immediately? Mass should be reduced by a surgical procedure and mesh repair should be done as a correct answer. So if you simply think about an obstructed hernia, what will you do for an obstructed hernia? Open it immediately, reduce the contents and keep a mesh. That's all. So mesh repair is done is the correct answer for this obstructed umbilical hernia. It is a straightforward question. An adult male presented to OPD with a fever and swelling in the scrotum, which was painful. Swelling was in relation to tunica vaginalis. This is testis. Testis is covered by the layer called as tunica vaginalis. There are two layers of tunica vaginalis like this. So one is parietal layer, another is visceral layer. Collection of fluid in this layer is called as hydrocele. So this is containing a fluid is called as hydrocele and which can be seen on a CT scan. So this is a picture showing you hydrocele. Patient having fever and swelling which is painful is probably because hydrocele got infected hydrocele. If the hydrocele gets infected, it is called as pyocele. In a pyocele, there will be associated pain will be there. That is what we call it as pyocele. 26th question. Which of the following is used in the treatment of GIST? So very commonly asked MCQ, gastrointestinal stromal tumors. The drug used is imatinib mesylate. What is this drug? It is a tyrosine kinase inhibitor. So tyrosine kinase inhibitor is called as imatinib mesylate. Don't forget this drug. It is CD117 positive patients. We give it's a tyrosine kinase receptor mutation. Such cases we will give them imatinib mesylate. So the answer here is C. So what is this instrument shown here? It is an instrument called as handheld Doppler. Handheld Doppler, also called as handheld Doppler stethoscope. It is a stethoscope of vascular surgeons. Like we use stethoscope for auscultating the heart, they use this, and this is kept on the arteries to look for the sound. So the sound variation, whether there is a narrowing or there is any obstruction to the flow, it is primarily used to measure the blood flow and detect flow abnormalities in the blood vessel. Answer is A. It is not used to localize the calcified plaques and thrombus. It is very difficult. Measure the systolic blood pressure. It can measure, but we can measure with a normal stethoscope itself. It is used to check the thickness of artery. All these are wrong. The best answer here is handheld Doppler is to measure the blood flow. Okay, blood flow. If there is a narrowing, there will be whoosh, whoosh sound will be heard when you are going for a narrowing of the vessels. Don't forget this. So here is a patient, structure preserved in the management of this case. This patient is having a lip cancer. And this patient is also having neck nodes. So lip cancer with neck nodes, what we will do? We will do wide local excision of the lips, plus for neck nodes, we will do radical neck node dissection or modified radical neck node dissection. So the question is asking about, this is a definite question, and this is a repeated NEET PG question. Modified radical neck node dissection versus radical neck node dissection. In radical neck node dissection, level of nodes removed are 1, 2, 3, 4, 5. So submental, submandibular, upper jugular, middle jugular, lower jugular, posterior group of nodes. Along with this, we remove SIS, spinal accessory nerve, internal jugular vein, sternocleidomastoid. Since I am receiving spinal accessory nerve, internal jugular vein, and sternocleidomastoid, patient becomes so much morbid. So this results in so much of morbidity. Therefore, we can also do another surgery in which we preserve SIS, accessory nerve, sternocleidomastoid, and internal jugular vein. All are preserved in MRND. So what is preserved in MRND? SIS, spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle. All are preserved in this modified radical neck node dissection for oral cancer. Don't forget this. So as usual, there are questions from urology. Which of the following statement is correct regarding this pathology? If you very closely observe, this is IVP. Don't get confused. It is a stag-on calculus. No, it is not stag-on calculus. If you very closely watch, you can see the IVP is flowing through this kidney down to the bladder. And from this kidney also it is flowing, but it is not flowing freely. It is having compression at this level, and there is a dilated kidney here. What is this? This is a pelviureteric junction obstruction. So in a small children, it is congenital pelviureteric junction obstruction. Etiology is unknown etiology. Please don't forget, we don't know why there is a pelviureteric junction obstruction. So this is a picture showing you congenital pelviureteric junction obstruction. The contrast is not flowing out of this kidney on an IVP. So nowadays, for congenital pelviureteric junction obstruction, IVP is no more used as an investigation of choice. MAC3 is the investigation of choice. MAC3 is a radioisotope scan, which is the best investigation for this. So this abnormality can be due to compression by artery or vein. No, there is no such compression by artery or vein. A is wrong. So congenital pelviureteric junction obstruction is not due to artery or vein. This type of pathology is better seen with MAC3 or renal isotope scans. That is correct. So it is not used for any study of renal function. 10%, 20%, that is and all is not anymore. It is no more used for renal function. 31st question, the given image is a Cox peculiar tumor. Can you see? There is a sebaceous cyst which got ulcerated. This is a Cox peculiar tumor on the scalp. It is a Cox peculiar tumor on the scalp. It requires incision and removal. Yes. It leads to osteomyelitis. Wrong. It can progress to squamous cell cancer. So treatment is reassurance. Wrong. So what should I do? The best answer here is actually we have to do excision of this. Excision of the sebaceous cyst. Instead of I and E, the better answer is excision. Therefore, it can progress to squamous cell cancer is a correct answer. So it can progress to squamous cell cancer. You should not forget this. 32nd and 33rd questions. I don't think they are surgery questions. They are ortho questions, but little related to surgery. So I have put here, a person fell from the train and injured his both legs few years back. Amputation was done as shown in the image. What is the most likely reason for such an amputation? See, you can see both legs are done below knee amputation. Such a below knee amputation is done for even smaller injury on even the injury on the ankle. We will go for below knee so that it will be helpful for them to put a prosthesis, not for stretchers or anything. It is mainly for using prosthesis. BK amputation patients, easily available prosthesis are there. So we go for BK amputation in many cases for making easy attachment of prosthesis. That is the answer from orthopedics. As a patient suffered prick injury over the palm as shown in the image given below. Which of the following correct statement about this type of injury? So following a prick injury, the palmar space got infected as you see here. So this is a palmar space infection. It is most commonly seen on the dorsum of the hand. It requires incision and drainage. It should be treated by removal of the cause. Yes, if there is any foreign body inside, we have to remove that. So this is a palmar abscess. Yes, it gives a frog-like appearance. It is most common on the dorsal surface. It requires incision and drainage. It should be removed by treatment should be removal of the cause. All these are correct statements. We could not get a proper recall, but palmar abscess related question came from orthopedics. Please have an idea about it. And other questions from other sources. The previous mid questions which I have discussed got from students of ARISE. And I have to thank ARISE for giving me this type of quality questions from a recall of their own students. So I'm so happy to acknowledge them at this point of time. And these are some other questions from some of my other student sources. So let me show you, these are all most image-based related, some question has come. Though I don't know the exact question, but I wanted to show the image. So this is a triple bubble appearance. Where will you get? Triple bubble appearance seen in jejunal atresia. Can you tell me what is this image? It is done for parathyroid adenoma. Tell me the name of the image. Yes, it is Sesame B scan. It is an image of Sesame B scan showing you parathyroid adenoma. So this is an image showing you the kidney fused. This is horseshoe kidney. This is a picture showing you horseshoe kidney. Okay, don't forget this. And this is a picture it was asked in the exam showing a renal mass. So renal mass is RCC. Renal cell cancer will come to you with the hematuria, mass, and pain. These are the three features of RCC triad. RCC triad is hematuria, mass, and pain. And some students have mentioned that they asked, what is this segment in the liver? See, this should be very simple. So liver segments, you should not have doubt. This is a falciparum ligament. Lateral to falciparum ligament, this is segment 2 and 3. Don't have confused. 4A, 4B is this. And this is a line we used to name Cantel's line, imaginary line, which corresponds to middle hepatic vein. So on lateral to on the right side of this is segment 5, 6, 7, 8. So this is the segments. So this segments you should not forget 5, 6, 7, 8. Where is segment 1? Segment 1 is a separate segment seen posteriorly called as caudate lobe. So it will not come in front view. So this is segmental anatomy. I heard that the question was marked. Which segment is this? And this is a CT scan question from hemorrhage in the skull. You know very well, if it is a biconvex, it is subdural. If it is a concavo-convex like this, biconvex is EDH. And this is concavo-convex called as SDH, subdural hemorrhage. Biopsy from the sigmoid colon showed one ulcer like this. See the ulcer. What is its shape? This ulcer is having a classical shape. Biopsy shows flask-shaped ulcer. Where will you get flask-shaped ulcer? In amoebiasis. So this question was also asked, flask-shaped ulcer in amoebiasis. So endoscopy, when I'm doing at 25 centimeter, what structure can be injured? At 25 centimeter, what structure can be injured on an endoscopy? So this is a classical question. Endoscopy at 25 centimeter contains arch of aorta and left bronchus. Arch of aorta and left bronchus are seen on 25 centimeter level. This question is a repeat question. Contraindications for Ryle's tube lavage. So number one, kerosene injection. When a patient has kerosene consumption, you should not do Ryle's tube or gastric lavage. Corrosive injection you should not do. So the two places you should not forget is corrosive injury patients and kerosene consumption patients. You should not do gastric lavage. And some question has come from hypovolemic shock related points. So in hypovolemic shock, please don't forget mixed venous oxygen saturation should be less than 50%. Cardiac output will be decreased and BP will decrease from class 3 hypovolemic shock. So cardiac output will be decreased, BP will decrease from class 3 shock. The first sign of hypovolemic shock is increased pulse rate. So they could not get a proper recall, but there are some points telling this question related to hypovolemic shock was asked in the exam. So these are the questions asked in the exam. I hope this recall helps to help FMG students to cover all the areas needed now. So FMG exam is now one step extra. So I request you FMG students, how to pass in these exams. I want you to remember 3 steps. Remember these 3 advices. If you want to crack in the first attempt, I'll always tell you, please remember these 3 advices. Number 1 advice is focus more on clinical subjects. More on clinical subjects. See, for example, clinical subjects like medicine, surgery, OG. So medicine, surgery, OBG. With these 3 subjects, if you are confident and strong, and read these 3 subjects, understanding the concepts. Don't read, don't mug up. Without understanding the subject, don't mug up. Medicine, surgery, OBG. If you are strong in these 3 subjects, you can easily crack 150 marks. It will cover basic science. In surgery, I will cover pathology, anatomy, physiology. Every area will be touching in surgery. So if you are strong in these 3 subjects, you should be strong in the sense, you should be strong like an INISET aspirant, not like a FMG student. You should not be just reading superficially just to pass, but you have to read like an INISET, NEET PG aspirant. You have to read these 3 subjects, focus and read in depth. I'm telling you again and again, if you are strong in these 3 subjects, with the help of medicine, surgery, OG, you can answer many other basic science subjects also. So that is focus on clinical subject is first important rule. Number 2, first of all, stop doubting. Stop doubting means many students will naturally think everyone will pass only after second or third attempt only. We cannot pass in first attempt. That is a first of all, you should erase that thought. There are hundreds of students who have passed in first attempt. So first attempt, if you pass, is the best attempt. If you are going to do the best and pass in the first attempt, that is the best attempt. So second attempt, third attempt, so many social problems will start happening for you. And second and third attempt preparation will be very difficult. So prepare with the sincere effort in the first attempt. So please read the medicine, surgery, OBG questions thoroughly. And third important is previous year questions. So 3-year questions of all subjects you must work out. So don't read superficially. Again, I'm telling you, 3-year questions of all subjects, just 3 years. No need of reading too much. Just 5 to 6 papers, 24 paper, 23 paper, 22 paper. That's all. 24, you will have 1 paper. 23, you have 2 papers. 22, you have 2 papers. Just read these papers. But don't read superficially. Read. If you have a doubt in the concept, take your material and revise that concept. So if you keep on doing like this, I'm telling you with this 3 advice, you will definitely crack FMG in first attempt. So I want you to crack FMG in first attempt and increase the national percentage of pass from 20% to 50%. You can increase the percentage of pass from 20 to 50% if you are going to do this perfectly. Don't read anything without understanding. If you can't understand anything, try to understand it and then read or just leave it. If you keep on hitting that same bush again and again, your time will be wasted. That is why I'm telling you, you will definitely understand clinical subjects. Whenever you get a chance to see some patients, go and see some patients. Don't think that you are wasting the time in the preparation. Just if you have a nearby hospital or nearby doctors who are seeing OP, you just go and see 1 or 2 days, you go and sit there. You will learn so much of clinical concepts there and you will understand the clinical concepts. So medicine, surgery, OBG, it's a key for pass in FMG. Stop doubting yourself and do previous year, 3 years question, at least 5 papers you should do. And I always say DocTutorials has become the benchmark in FMG exam because we have our team working out in abroad itself and we are having classes in abroad. So definitely all the classes in DocTutorials are finely tuned according to FMG students, and follow this channel for more updated exams and series. And if you want to have so many questions and discussion, you can follow me on Telegram or Instagram on Surgery Sixer, or you can see many of my FMG videos in my YouTube channel, or you can download the PDF. This PDF will be available in Telegram channel. You can go and go through that. Thank you all, friends. I hope most of you will be seeing the session again in the post-recorded session. You'll be seeing. Go through that and do well. Thank you. If you can stop live.
Yes, sir.
Yeah. This recorded version you give to Bindu. Okay.